I am Dr. Surekha Devi, Senior Consultant in Transfusion Medicine. I am working at Birthright by Rainbow. Blood transfusion is given as a part of the treatment when a patient's hemoglobin drops to certain level, and that is called as anemia. When there is anemia, then blood transfusion is given. We are going to talk about intrauterine blood transfusion, which is given during pregnancy to the fetus. And this is given as part of treatment to treat hemolytic disease of fetus with evidence of fetal anemia, which is due to the Rh isoimmunization. It is to treat the fetal anemia, we give the intrauterine transfusion. This is given after 20th week and before 35 weeks of gestation. There are various diagnostic tests to detect this hemolytic disease of newborn having fetal anemia. One is we go by the serial titers of maternal antibodies. We do the titrations. Depending on these titers, sometimes the titer goes beyond the critical level of 1 in 32, or if there is rise in titer, then that is one indication. And one more important significant diagnostic tool is the Doppler ultrasound measurement of peak velocity in fetal middle cerebral artery. Based on these two findings, the fetal medicine specialist, she decides whether there is fetal anemia or not, and they check even the fetal hematocrit also. Based on those levels, they take a call whether to give intrauterine transfusion or not. So that is when they send us a requisition to the Department of Transfusion Medicine, where we prepare the red cells as per the specifications and then issue that blood to the patient. One is we check the blood group, and the other one is we check for the antibody screening. If the antibody screening is positive, then we check for the identify the antibody, what type of antibody. There are some antibodies which are responsible for the development of hemolytic disease of fetus and newborn. So depending on the type of antibody detected, then we go for the antibody titers. That is, we start doing these titers right from 12th week onwards, and from then onwards we see the titer. If the titer is quite significant, and we keep on checking every month, up to 28 weeks we check for the titers, and that is up to 28 weeks we check every 1 month for these titers, and beyond 28 weeks up to 36 weeks we check once in 15 days. So we see whether there is rise in titer. So it is a rise in titer which is more significant, that suggests that the fetus has developed anemia. Apart from these maternal antibody titers, we also go by the Doppler ultrasound measurement of middle cerebral artery of the fetus. So depending on the velocity graphs and all, they decide whether there is fetal anemia. Based on these two findings, the fetal medicine doctor decides whether to give a blood transfusion. If the mother is Rh negative and if the baby is Rh positive, or if she has been sensitized in the first pregnancy, then these maternal alloantibodies arise, which gives rise to hemolysis in the fetus, extravascular hemolysis, then that leads to anemia in the fetus. So if the mother is Rh negative, that is D negative, and if the fetus is D positive, extravascular hemolysis in the fetus, which gives rise to fetal anemia. It's like timely intervention. Our services are always emergency. It's always timely intervention. We have to provide timely service to the patient and the right product at the right time that saves the patient. In O negative red cells, there is no antigen. That's why we call this as universal donor also. In cases of emergency also, suppose if we don't get or if we don't have time to check the patient's blood group, we give this O negative red blood cells as for the transfusion for life saving. Similarly, since we don't know the fetal blood group at that stage, and we are selecting a donor who is O negative and who is also D negative. D negative means that is D antigen is negative. By that, there are no antigens in the red blood cell, which is quite safe to give to any group patient. So when we are counseling the patient's family, we tell them to bring a O negative donor who is preferably a male donor and who is not related to the patient. The obstetrician who during their antenatal checkups, they detect this condition, that is prenatally. So they send the patient sample to us, we give the report to them, and they also do these Doppler studies of the fetal MCA, and based on all these findings, they come to a conclusion whether the fetus has anemia or not. that is also called hemolytic disease of fetus. Examples: if the mother at the time of delivery, if they have severe bleeding, we call it as postpartum hemorrhage. That is also quite challenging for us to issue blood products. Within that time limit, we have to issue multiple blood products, like say some 40 to 50 units of the various blood components. Not only red blood cells, we give other blood components like fresh frozen plasma, cryoprecipitate platelets, which we separate from the whole blood donated. So all those components we issue within a span of 2 to 3 hours. So is it not challenging? This is life-saving for the patient also. We arrange everything. There are very sick patients in the ICUs, like in an NICU or PICU. And even we cater to a lot of patients who undergo pediatric cardiac surgeries. That is one area which is also very demanding, and we issue a lot of blood products, various components to those patients. And ranging from common blood group to rare blood groups, we arrange everything. In timely management is quite very important in our area of work, which saves the patient and it improves the quality of life of the patient. Apart from red blood cell transfusion, there is another concept of giving intrauterine platelet transfusion to the fetus, but in a different disease. That is called neonatal alloimmune thrombocytopenia, NAIT, which we don't come across so frequently. It is a little bit rare condition where we can treat the fetus prenatally. By there, the patient develops low platelet count. So prenatally also we can give, after diagnosing NAIT, we can give intrauterine platelet transfusion to the fetus. In that case, we go for the maternal platelets. We collect platelets from the mother by a procedure called platelet pheresis. We process single donor platelet concentrate from the mother, and that we irradiate. Later, we give it to the fetus. So this is also, if diagnosed prenatally, this is a treatable condition. But here we give intrauterine platelet transfusion. They are one type of cells present in the blood. We call it human blood, which has various components. The cellular component is red blood cell, white blood cell, platelets, and then the liquid component is called the plasma. And even this plasma again further is fractionated into cryoprecipitate. So these are various components, these are called components, which we separate from the whole blood and we store them in our respective storage equipment, and accordingly we do some tests and we give it to the patient at the time of requirement.